5:32. So I just want to welcome everybody here. And I'm Dr. Julie Cantor. I am really excited to share this conversation with you. And thank you to the audience for being here and welcome. Let me go to the slides for a quick minute. I'm going to share my screen with you so that we can properly introduce everybody and make sure we're all on the same page here. So this is our topic tonight, and I hope that you saw it on all of the channels that you may be on, LinkedIn, Twitter, and again, thank you so much for joining us. This is a couple of slides, like I said. If you want to see a side-by-side mode, here's how you do it. You can go to your options and go to side-by-side mode. We will be in and out of the slides, so you can decide how you want to handle that. A couple of webinar logistics. This is not a meeting, it's a webinar. So you don't have to worry if you're a participant out in the audience, if you're an attendee, that you're going to be recorded, that you are not muted. The only people who can mute and unmute themselves by video or audio are our panelists and me. So no worries about that. If you have any questions or comments, we're going to try to see however many we can answer. Use your Q&A and put them there. If we're unable to get to them, we'll have a way to follow up with you. We can follow up with you by email. There will be an email at the end of this webinar. It'll go out tomorrow, which will give you further information and resources about these topics, and also ways that we can continue our conversation, because we're hoping it's a great one. In terms of the recording, this webinar is being recorded. And if you're interested in using it for some, purpose at your institution, definitely you can let me know and we'll see if we can help you with that. In terms of our roadmap today, this is going to be a conversation and we're gonna have you share in the conversation. I'm gonna have the panelists introduce themselves and briefly tell you a little bit about the issue. I may do that. I'm gonna do that first, and then we'll have our conversation, then we're going to go from there to an action plan. So why we're here and why you're taking time out, and I want to thank you for taking time out, is to focus on this rather endemic phenomenon of workplace bullying and harassment of surgeons who are female. And we're having a particular focus tonight on interprofessional interactions, that is with non-physicians. There are lots of resources out there about bullying generally. We can talk about some of those, and there are plenty of resources and research done on bullying in general. And we're taking a look tonight at the issue of interprofessional. So nurses bullying surgeons, things along those lines. What do we mean by this term? It's a little bit of, I know it when I see it, but there are definitions of it. And let me give you one. An accepted definition of bullying by an expert on school-based bullying includes three components: aggressive behavior that involves unwanted negative actions, a pattern of behavior repeated over time, and a real or perceived imbalance of power. And even though you might think that the balance of power tips to the surgeon, as we're going to hear, the power imbalances may be quite different than what we would expect. Why does this matter? It matters for a number of reasons. It matters because it's mean. That's the first thing. And it really inflicts harm on the people experiencing the bullying. I think people can probably think back on their lives when they've had been on the side of being bullied. And the fact that you remember it as opposed to, what you bought at the food store last week really says something, I think, about how it affects all of us. The second thing is social norms. We have to ask ourselves, what kind of a society do we want to live in? Is this how we want to treat each other? Is this how we want our children to treat their children and treat others in their world? We want to have a society, and I think we can all agree on this, that's kind. It's just better for everyone. Another reason is that it actually may be illegal. This discrimination. There may be discriminatory elements, the gender issue that we're going to talk about today, the issue of a hostile workplace. All of those things may fall into several different legal theories, and there can be long-term legal strategies to deal with them. But to the extent that people are institutionally liable for that, that may be a real problem for your institution, or people who are in charge of the institution or general counsel out there may really want to take a hard look at that. because it's not just something that can be free. It may be very expensive for you to deal with at some point. The fourth reason that I think this matters, and this is not an exclusive list, but is that surgeons are, especially the kind of specialists that are on our panel and that are out there in the audience, and just generally speaking, becoming a surgeon reflects decades of very hard work. And people are not easily replaceable. And even if you're like, well, we can get a new fill in the blank surgeon, it's not kind to the person who went through all that training. So I think we need to recognize that. And then if you think that all of those things are really not that important to you and you really don't care, and in fact, you just don't like female surgeons for whatever reason, okay, but think about this. If you're in healthcare, you have a responsibility, a duty to patients. This is bad for patients, full stop. And then with that, the flip side of that coin is that you may one day, I would almost bet on it, you will one day be a patient. And you may very well be a patient on an operating room table, and you really want your surgeon to be at her best. And you want the team to support everybody on the team. So with that, let me take one more moment to introduce this topic, and then I'm going to pause for the panel to introduce themselves, and then we're going to come back to a slide. So here's one study that looked at this issue of interprofessional workplace conflict, and it found that it was prevalent. It found that the surgeons who were female identified what they thought was a double standard, that men wouldn't be treated this way, and that there was an expectation that they conform to gender norms. And we can talk a little bit about that, this sort of discrepancy between how society has told women, at least over the decades, centuries perhaps, how women should behave and how surgeons should behave, and that kind of inherent conflict and what that may mean. And then the negative consequences to their professional and personal well-being and their professional reputation. So I'm going to just pause for a moment to stop sharing my screen. And I'm going to ask our panelists, first of all, welcome panelists and welcome to our participants. Wow, we have a lot of participants. Thank you for coming. Let me just go around the panel and ask you to introduce yourselves to our audience. And I want to thank everybody for being here. So I'm just going to pick randomly. Dr. Temkin, do you want to begin?
I knew you were going to pick me first, and I don't know what to say. Other
You're
than
right there on my screen. I'm reading across my screen, really.
I am a gynecologic oncologist. I think people don't always know exactly what that means. But after after going to medical school, then I did an OBGYN residency, and then I did 3 additional years of surgical training to be able to really manage any complex surgical issue that can happen in a woman's pelvis, whether it's related to her reproductive tract or her bowel or her bladder or her genitourinary tract. I actually became a GYN oncologist because I loved surgery, but over the years, really figured out that I loved taking care of cancer patients more than I love the surgery. And I'm here today, but I need to do both to really care for my patients. I am here today because of lived experience of being bullied, of gender discrimination, and that have really changed my career. And I guess it's like over 20 years since I graduated from medical school. And I would hope that the next generation of women has a different experience in their surgical careers than I have had.
Thank you so much. Let's go to Dr. Wright.
Hi, everyone. I'm Kelly Wright. I'm Division Director of Minimally Invasive Gynecologic Surgery at Cedars-Sinai, which is a large hospital out in Los Angeles. And so I run a busy division of surgeons, both male and female, and I want to preserve our careers as long as possible so that we can care for women, who have surgical issues in the best way that we can. And so this issue is important to me because, like I said, I want to preserve our careers, but also take care of patients in the safest and most efficient way possible. So I'm really honored to be on this panel with some people that I really respect in our field.
Thank you, Dr. Wright. Let me go to Dr. Pei. And Dr. Pei is in the middle of, in between surgeries. So thank you for being here.
Oh, not yeah. Thank you so much. I'm honored to be here. I'm just on call to be on. I'm just on call for potential surgery.
Okay.
But yeah. So I'm Kevin Pei. I'm program director of general surgery residency at Parkview Health, and I actually recently left academics in the sense of a university, partly because of an increasing toxic culture. And as a program director, I feel like it's my duty to really promote a positive learning climate, free from workplace incivility, bullying, and harassment. And I really do believe, because there's that really profound and clear power dynamic inherent to the structure of faculty versus residents, that it's our job and my job to protect our residents. So thank you all so much for having me.
Thank you so much. Dr. Vandis.
Hi, Julie. Thanks for having me. It's so great to be on the panel with all these amazing experts. Like Sarah and like Kelly, I am an OBGYN. And I actually did go into OBGYN because of my attraction to surgery. But I mostly practice obstetrics right now, though I did a surgery this morning. But I'm an OB hospitalist. I work at USC Verdugo Hills. And I also care deeply about this issue, so much so that in 2017, I decided to create a company that measures gender equity and equity overall in healthcare and now outside of healthcare. So our company provides analytics so that healthcare organizations, hospital systems, medical practice groups can use diagnostic tools to measure inequities so that they then have a process by which to create a roadmap towards equity. We just finished up with a client, and the CEO, after we got done with our presentation, said that it was a very transformative moment for him to really examine the depth of inequity that existed in his culture, and that he was really, really motivated to make substantive changes. So change can happen, but it takes a lot of work, and I'm excited to be on this panel and discussing it.
Yeah, that's so great. And I want to let's put a footnote there, or put a pin in that, because sometimes change takes equipment, it takes a lot of money, it takes a lot of resources. I want to ask, as we get toward the end, is this something that really takes all of that, or does it just kind of take maybe a mental shift that doesn't cost any money? My hypothesis is the latter, as you can probably tell. And I was struck when I chose a school for my son. I wanted a place that was kind, and I often talked about that issue with the director of that school, and that it struck me that the culture that they had established at that school didn't necessarily cost any money. It wasn't about books, it wasn't about computers, it was about a culture of kindness. And so I just want to come back to that issue as we finish introducing the panel with first Dr. Tatem, and then we'll finish up with Dr. Miller and get into our discussion.
Hey, everyone. I'm very humbled to be on this panel of very distinguished members. I feel a little out of place. So background on me, I am a urologist. I trained here in Indianapolis, the same city where I currently practice, where I did residency. And then I did a fellowship in male reproductive and sexual medicine. And I am here tonight because I come from a place of incredible privilege. I am a cisgender, heteronormative, white, Anglo-Saxon, Protestant male, born and raised in the deep South. I drive a truck, and now I'm practicing in the Midwest. But I'm here because I'm passionate about my friends and my colleagues. And as I went through training, I witnessed a lot of challenges and injustices that were just deeply, deeply upsetting to me. Residency and surgical training are hard enough. And whenever you're standing there arm in arm with your colleagues, and then you see someone so close to you get kicked and kicked again, just by the nature of who she is, it really hits home with you. And so I am here to not just, I can't talk to any of my panel members and teach them anything about diversity. I am here to learn, but I am here to entreat those who maybe look like me and maybe come from a place of privilege like me to be open-minded and to be considerate and compassionate to your colleagues and listen to them. Because the truth is that the the hurdles that I have had to see my female colleagues overcome and endure absolutely floor and astound me. And I want to be part of the change that makes it easier for future generations, not harder.
Thank you so much for that. That was, I think if anybody needed like a snippet right there, we can just take that. That was really well said. And thank you for being on this panel. I really appreciate it. And Dr. Miller, please introduce yourselves. And then I want to go to the tweet from Dr. Tatem that started, well, that piqued my interest. And I thought, let's continue to have that discussion. But I want to thank Dr. Tatem for that initial tweet. And we'll get there after we hear from Dr. Miller.
Good evening, everybody. Let me just also thank you, Julie, very much for providing a platform for us to have this discussion, and hopefully it's just the first of many. You've been a tremendous ally, and I personally really appreciate that. And I'm glad that to see everybody else on the panel. So I'm a general surgeon. I finished training in 2002, so it's been a couple decades almost practicing in general surgery. And I think I sort of had the misperception that after general surgery residency, where a lot of people are being abused, that my life would get a little bit easier as an attending surgeon, which was really not the case. And I also practice hospice and palliative medicine, which I decided to do through my work as an acute care surgeon. But I'm currently not working clinically, and a lot of that has to do with the issues that we're going to be talking about tonight.
Well, that piques everybody's interest. We'll want to hear about, we'll want to hear about that in about a second. I'm going to go back to sharing my screen because I want to bring up this tweet from Dr. Tatem. Dr. Tatem, could you don't need to read it for us, but could you tell us a little bit about the situation and what inspired you, I suppose, to raise it in a public forum, building off of what you just said, using using who you are and all of those identities that you mentioned, and really raising it as a rallying cry that this isn't okay. This is, it's not okay during residency, and it's not okay when you're an attending. And we can hear from Dr. Miller in a minute, and certainly others on the panel who've experienced, who have been on the receiving end of this bullying. Because I think we first want to get some stories on the table, and then we'll shift into some solutions. So Dr. Tatem, why don't you start us off with this tweet and what was going on here? What were the responses? What did you notice about them? And what made you want to bring this up in a public forum? And again, I want to thank you because this was the tweet that inspired this panel. So, but for the tweet, there would be no panel.
Yeah, well, thanks, Julie. So I was very blessed to have one of the tightest and the closest residency classes that has come through our institution or through where I did my residency in a very, very long time. We immediately bonded, and we started a text chain before we even got there for our intern year, which we still continue to this day. I just got off with one of my co-residents, a few hours ago, and despite being, year and a half out, from fellowship, so 2.5 years from finishing residency, we still talk constantly. And that was probably the only way that we survived our training and institution that, duty hours, it's a guideline. But the thing is that as we went through training, everyone gets kicked in the teeth. Okay. You just accept that as part of surgical training. You take it on the chin, you suck it up, and you move on. And we would constantly share these stories with each other. And I would notice that, me and my other male classmates, we'd share it and be like, oh, that sucked. Okay. Yep. I had the same thing happen. Move on. But the tone and the tenor that I heard from my female co-resident was a little bit more personal. And the things that she had to deal with were seemed a little bit less appropriate. Like, I mean, I don't know if a nurse would speak to me that way, but what Dr. Miller just said really hit it home. You know, we graduate, we go on to our training, and we're like, oh, thank God this is over. That is not true for my female friend. And she was texting one morning, and we talk quite frequently about how here she is, a badass surgeon, so good at what she does. I mean, good Lord, she could operate circles around me. And she is there in practice. She is struggling to get the type of referrals that are, you know, would reflect her surgical skills. She's having a hard time dealing with this sort of inherent bias that she seems to encounter. But one morning goes into round, is irrigating a patient's catheter, which is a bloody, messy endeavor, in case anybody is curious, right? This is not subtle. If you walk in on a urologist irrigating a bloody catheter, there is no doubt that they are extremely busy and they don't have anything else. Like, they are engaged in that. And the nurse, you know, asked her, oh, hey, whenever you're done with that, can you clean up the patient's food tray? And this is, you know, my friend who is, you know, about to be a board certified, you know, urologic surgeon who's covered in blood and urine trying to help this poor gentleman who can't empty his catheter. And she told her, I'm the surgeon. And then all of a sudden the nurse says, oh, I know, but, you know, we all need to pitch in, you know, right? Doesn't matter. And I could not, she was floored. She was gobsmacked. She ended up, I don't know the exact details of how it resolved because she was seeing red at that point, but she shared this with me later, and I was so infuriated on her behalf. She doesn't use social media or anything like that. She probably is much healthier for it. But I was so frustrated. We exchanged texts over it, and I just felt compelled to share that with the audience at large because I have a feeling, and as we're going to learn tonight, this is not a single occurrence. This is a pattern of behavior, and this may seem like a small thing, but this is representative of a mountain of weight and discrimination that is being unfairly put forth upon, you know, our female colleagues. And so that was the genesis and the story behind that tweet.
Thank you. And I want to hear from the panel, but before I do, and you guys definitely don't have to wait for me to call on you. You can, you know, we can kind of open this up and you can unmute yourselves and we can just jump in as a conversation. But let me share, when I posted this on LinkedIn about our panel, a friend of mine who is been in practice for decades, and you can see him here, you can look him up. He's a great, terrific guy, terrific surgeon, terrific guy. And you can read with me what he said here, that something very similar happened to a surgeon I know. She was asked to clean up a procedure room in which she had just saved a life. And so of course, I said what I said there, and I said, how often are you asked to clean up your procedure rooms? And you can see he said never. So just, you know, that's again, just one instance. And here's another instance that Dr. DuPont posted on Twitter that she thought, from her point of view, her perception was that she got along with all the staff, yet she was told here, saying indirectly through colleagues and never even to my face, that I was, quote, unapproachable, intimidating, and didn't smile enough. Yet doctors who yelled in the OR, everyone was like, okay. So let me turn actually to Dr. Temkin. You posted this. You want to tell us a little bit about your experiences, and then we can kind of go around the horn. I'm gonna, after you talk about this slide, I'm gonna stop sharing and we can just go back to the screen for people who are not able to be in split screen mode. You'll be off slides in a second.
Yeah, so that's, I mean, I think it's a tiny bit different, but it goes to like what expectations are of women compared to men who are surgeons, right? So the blacked out stuff is the date of this, because I guess I didn't think it was relevant, but you know, this was a situation where I was actually formally reprimanded by my institution, and this was the example. This was one of two examples. The other one's not worded really appropriately for social media, but I can say what it was. But this was one of the examples of how I had been in civil, I guess. And I remember the incident because, I was finishing clinic in a workroom and a nurse came in to tell me that, asked me about a patient. And then she said, well, the resident told me to do something else. And I said, oh, she doesn't know what she's talking about. Like, I had more information than her, right? And then you can see the resident wasn't even in the room. So I just don't even I can't imagine a world where that would have been a formalized complaint from the nurse if I had not been a woman. The second part of it was that I had pulled patients out of the waiting room that on a day that the front desk staff was very behind and I was behind. And so I just was like, oh, I'll just let them check in on their way out, just to alleviate the cluster. Like, there were old patients standing in the cancer center. So I don't think either one of those would have risen to anyone's attention if it hadn't been coming from an expectation of me as a woman not being maybe a little softer than I am innately.
Dr. Miller, I wanted to come back to you. I said I wanted to, and so let me do that. Can you share a little bit more about whatever you're comfortable with about, you mentioned that you're not practicing at the moment and that the issues that we're talking about here today had something to do with that?
Yeah, sure. So there's an accumulated burden, I think, that we share around being able to do our jobs safely, for our own personal safety and for the safety of our patients. And for example, this is just one of many different experiences, but earlier in my career, I was operating on a patient who was unstable, and the circulating nurse who had been assigned to the room was known to be hearing impaired. And I asked for something that I needed emergently, and she couldn't hear me. And so I just progressively escalated the volume of my voice until I was, not yelling, but speaking very loudly. And at the end of the case, I was written up. And so the burden of this, circumstance of patient endangerment became my problem and my behavior, and not the fact that the institution was employing someone who, wasn't able to hear what the surgeons were requesting in the operating room. And I think that this shifting of blame is something that's, really catastrophic, because if you're a surgeon who needs certain things at certain times, and this is, in the OR, this is out of the OR, but simply requesting those things becomes a burden on the staff, so that you can't have those things that you need to take care of the patient. That's where the patient endangerment comes from. So I guess, in summary, what I would say is that it becomes really difficult to figure out how to do your job well when you're not empowered to do your job. And that's a double bind. So I should have also said in my introduction that the experiences that I've had and the cumulative experience that I've heard from, colleagues, some of whom are in this panel, has inspired me to found Physician Just Equity. And I don't want to take up too much space with that, but it's not like I don't have anything to do. Just because I'm not, practicing clinically right now.
No, absolutely. And one of the things that I want to highlight, and for people on the other side, the participants, in the email that I'll send tomorrow to follow up, I will share these resources with you. I'll share the link to Physician Just Equity. Dr. Temkin is directing, is that producing? She's the executive producer of a documentary called 1001 Cuts. You should all follow. I'll put in the Twitter, all the social media as well, so you can follow. You'll have the option. You don't have to do anything, but you'll have the option to follow people, and I'll make it easy for you. So thank you, Dr. Miller, for bringing that up. But I do think that it's interesting, especially now, the time during the pandemic. It seems like we need all hands on deck, and to have anybody step away from the workplace because of bullying, that has a gender discrimination or any other kind of discriminatory element seems frankly appalling on so many levels. So I just let's just keep that in mind as we hear from people like Dr. Miller and people in the audience who have had those experiences, people who are going through it now and still slog through it and get up and go to the hospital and do their job and take care of the patients the way they can. Dr. Pei, I want to just turn to you and ask how you perhaps tried to deal with this in an academic setting. I wonder if, as a leader in the residency program that you were directing in the academic world, did you try to create change? And I know maybe the gender overlay wasn't totally maybe at the fore, or maybe it was, but how did you deal with perhaps trying to make institutional change? And were you greeted with open arms on that? Were you given resources? Were people saying, yeah, yes, we see this and let's fix it? Or what was your take on that? This persists. I read, gosh, I don't even remember that, like this is a related but not directly on point, but the story of Libby Zion and in terms of workplace hour issues. And Dr. Tatem, you mentioned workplace hours being a kind of a guideline, sort of just a suggestion. Different, but that power differential is there. I'm wondering, Dr. Pei, and I know you've written on the issue of workplace bullying generally, if you have any thoughts for us about pushback. You were so committed to making change that it sounds like you even made a career change. Tell us a little bit about that.
Yeah, thanks for the chance to share. If I could make a comment on the Dr. Tatum's tweet and the story about the nurse asking a female urologic surgeon, and really that one that your colleague shared about asking a female surgeon to clean up after their procedure. That opinion piece that I wrote was called The Perfect Crime, because you know what, in these two circumstances, we all know that women are being treated differently, and yet it would have been incredibly difficult. And I want to focus on a little bit on this concept of reporting and protocolizing of how we respond to it. I can actually play out those two scenarios in my mind where I would have such a hard time following up with it, because at the end of the day, it sounds like, well, what's wrong with asking you to clean up after your procedure? Or what's wrong with after asking you to help out and chip in with the patient's tray? And that's difficult, because at the face value, there's nothing wrong with the comment, well, we should all pitch in, right? The problem is you're not asking that of the male colleagues. You're not asking that of, you might be asking of the resident, or you might be asking that of the female residents, but you're not asking that of the male residents, right? There's all sorts of power dynamics, there's gender issues going on there. And so institutional change is hard. You alluded to that very early on. Institutional change is very, very hard. When I first started on this journey about workplace incivility and bullying, to me, the right answer was always to call it out on the spot, to always stand up for the victim right on the spot. And in fact, as I've been doing this for a much longer period of time, I've learned that we actually have to be strategic, because when you call things out right on the spot without thinking about it, you could actually make it worse for the victim of the bullying. And so we have to be more strategic about it, number one. And number two, we really have to, it is really the onus is on the institution to have zero tolerance policies that are actionable, not just words. I would say that probably 95% of institutions, if they even mention bullying of this type at all, it's not actionable. And so I actually personally, I don't have the perfect solution at all. I know that we're working towards strategies of actionable zero tolerance policies, actionable anonymous reporting structures. But I don't have a perfect solution or even a good solution about how to make things actionable at your institution. But I think that's the direction we need to go.
I was speaking to, thank you so much for that. That's really helpful. And yeah, the title of your piece was great. The Perfect Crime. It was really quite pointed. I was talking to somebody who runs a business, and she was telling me that when they bring new people in, they talk to them about their particular culture, and they call it being, the name of her company. So let's pretend it's Apple, like you want to be an Appleite, you want to be whatever, you want to be like, it's a way of speaking and a way of behaving where that's how we do it. And in her particular company, which is a food services company, people are called, the people who come in and purchase food are the guests, and things like that. And it starts really at the top with the CEO wanting to create a culture. Dr. Van Dis, as a CEO, what do you do in that sphere to create a culture? And also Dr. Wright, at your institution, and Dr. Van Dis at your institution, what do you see going on this level, especially in terms of gender? Do you see anything? Dr. Pei mentioned, and I've heard this mentioned by other surgeons in academics and elsewhere, zero tolerance. What can that look like? And I see we have some questions coming in, so let's talk about this, and then I want to have a couple of minutes to take those questions. And Dr. Temkin, I know you can see these questions. Take a look at the question about why we accept this from female surgeons and not male surgeons, and perhaps you, Dr. Tatem and Dr. Miller, can chime in on that while we listen to Dr. Van Dis and Dr. Wright.
Yeah, well, I just want to say, there's actually a lot of evidence that female surgeons are more likely to be written up by scrub techs in the OR, by residents, by medical students, and by colleagues. So what it really boils down to, I think, is it goes back to that comment about the food tray, which is that when women exhibit leadership behavior that is agentic, that is to say, more of the types of traits that are associated with being a man, she is criticized for that. So women are supposed to, according to cultural norms, have communal behavior. And so what that nurse said to that female urologist was, you need to exhibit communal behavior, and that is being a team player. And I can tell you in the research that I've done is that team player is actually synonymous with criticisms about women in medicine. Men are not criticized for being a team player because they are always thought to be the lead, the captain. And so really what happens is that women surgeons especially bump up against inherent gender norms. And I want to bring something forward because I'm worried we're going to run out of time, but I want the audience to know that this disruption that happens in medicine, and especially in the operating room, it does, to Pringl's point, have real important ramifications for the safety of the patient. And I think that those who aren't surgeons, or maybe who don't know what an operating theater feels like, for those of you who might have seen the video last week of the surgeon who was responding to his traffic ticket in court on video, everyone watching that thought, oh my God, I wouldn't want to be that patient. That doctor is distracted, right? Well, that distraction happens all the time to women when they're operating, right? Because when women are criticized, when women are not handed the instrument they asked for, when women are, pejoratized or made to feel lesser while they are in fact the surgeon, not only does it feed into women's over preponderance of imposter syndrome, but it fundamentally is disruptive to the surgery. And I've absolutely seen instances where the confidence, the ability of the woman to operate is threatened by the disruptive behavior in the operating room. So just as you would never want to be that patient while the surgeon's responding to his traffic ticket, you also don't want to be the patient when the female surgeon is having to fend off aggressive, disruptive, unsupportive, uncooperative behavior in the operating room.
Yeah, one thing that I think
my
about
nightmare. The nightmare that I wake up with in the middle of the night is that no one will bring me suture. That I need suture and no one will bring it.
Oh no, I was just going to say I know everybody, well, probably most of our participants are familiar with the operating theater, but to the extent that people are not, think about it being on a plane with a pilot. And, you want your pilot to bring her A+ game, and anything we can do to help her fly that plane is great, because we're all on board. So just to, maybe bring a parallel, it's certainly not a perfect one. But let me go to you, Dr. Wright. And then I see that we were slated for 45 minutes. We have a couple of questions that I'd like to get to the extent that our panelists need to go at that time, because that was the slot. No problem at all. To the extent that participants need to go, no problem. If folks want to stay a little longer, also okay. I will not end it just because of an arbitrary time. If just reading the room, people are still interested in the conversation. So let's hear from Dr. Wright, your thoughts and some institutional work going on. And also, I know, congratulations, you were recently, I want to say, granted permission to study a related issue.
Yeah, thank you. I'll talk a little bit about that. And just to piggyback on Dr. Van Dis, I think I was first introduced to the concept of gender schemas by Dr. Caprice Greenberg's presidential address to the Academic Surgery Society. If you've never seen that, please Google it. It's a fantastic hour-long talk about gender schemas and how women are expected to be communal. So how do we do that when we are in a role where we really need to lead? We need to take off, we need to land the plane. And as a female division director, what I've tried to do is always bring it back to patient safety. So all of us care about patient safety. We're all like-minded in that goal. And so when there are players that might exhibit bullying or discrimination against female surgeons, I'll often go to the charge nurse and say things like, we're doing really great here, but this person just isn't keeping up in the OR. We really need a really strong advocate for these GYN patients. They deserve a strong OR team. And bringing it back in that communal way and trying to be positive about it, I have found has gotten us some success. Because this is not just about female surgeons, it's also about female patients. And there was a recent abstract presented, I think, at the American College of Surgeons on torsion. And they looked at patients who were diagnosed with torsion, either testicular torsion versus ovarian torsion. And the decision was made, we are going to go to the operating room to correct the torsion. And the female patients had to wait, I think it was twice as long to get to the operating room. And the female surgeons encountered even further barriers in time delays to get to the operating room. These are surgical emergencies. So it's not even about female surgeons. And yes, we want to promote that long, healthy career. But when we bring it back to the patient, every institution is motivated to promote patient safety. So in the absence of structure and policies where we're able to take, actionable, where we're able to take action against bullying, in the complete void of that, we can always bring it back to patient safety. And I think that's where we have to really start and end.
And I like how you just recounted that. It sounded like you were doing a compliment sandwich with the charge nurse. Like if I can recall, like you started out saying something positive, and then you rolled into, we need to have a strong OR team. Then you shifted for the patient, and then you came back to another compliment. So I'll just kind of, footnote there to everybody who wants to look up compliment sandwiches. I think that was, quite well done. I want to be sure that people who need to go hear this important question. I think we've talked a little bit about one of the questions that came up, which is, why are we okay with male surgeons who are demeaning and bullying, but we're not okay with female surgeons? I think the idea that you're bumping up against the way men, quote unquote, should behave in a society, the way we've seen them behave on TV, and then, women are supposed to be nurturing and, those, I guess, more typical feminine characteristics. Dr. Temkin, you brought up a great slide on this issue in your recent grand rounds, but there's kind of a disconnect between those, and that may make people uncomfortable. Maybe they just don't like people. There are a whole bunch of, reasons for that. But I think when we get into gender stereotyping, there may be some answer there. So let me just stop with that. And actually, let me bring this one question back to Dr. Wright, and actually Dr. Temkin, and everybody can jump in. I have a comment here. I've tried to bring it back to caring for the patient, but I've still been written up, quote, because of the way I said it. What do we do with that? I mean, come on, you got like.
I mean, this just shows
I,
this very, very fine line that women have to walk, right? Where I mean, I don't think that I could speak about gender roles any more eloquently than Dr. Van Dis just did. But you know, we have an expectation of women that that we're communal and that we're kind and that we're warm and we're friendly, but it's actually a minority of women who actually have feminine type personalities, just like it's a minority of men who have masculine type personalities. When you go back to look at, you know, some of the original research in this topic that was done in the 1970s. And what happens to women who are surgeons, because being assertive is in conflict with the gender role for women, and women who are assertive become perceived as being aggressive, which is a total violation of gender roles for women. You know, we're constantly trying, like, I mean, I love what Kelly's saying, but at the same time, like, why are we needing to have like figure out the compliment sandwich? Like, it's just like, we need better staff. Like, there doesn't, I don't know why, you know, like we're trying to
it's so
sugarcoat
true.
it in this way.
I
Like,
think it's a survival mechanism.
Yeah,
and I agree. I mean, like, why can't it just be, you know, this happened, unacceptable. I'm seeing, you know, I'm going to bring in a comment here, and Dr. Miller, I see, I want to get to you, but this, I'm going to fold in another comment from our participants here, which is exactly this, that on a routine case, she is calm and, quote, fun and polite, but on an emergency case, she's still calm. But instead of saying, please hand me this retractor and thanks so much, she might say, hand me the self-retaining retractor, and all of a sudden people start eye rolling. Oh, she's aggressive, she's bitchy. How should she deal with this in the case? You know, how do you deal with this? And then, you know, Dr. Tatem, Dr. Pei, like, what you know, how would you guys deal with this in and outside of an academic institution? I mean, I agree with the idea that you have to have a whole presentation about a comment like, we've got to have better behavior in the OR. And then if you say it in that way, it's like, you know, that was an aggressive way that Julie spoke to me when she said that about whatever. It's just so kind of Kafkaesque I'm an outsider. So from an outsider's point of view, it is absolutely maddening. And like, hats off to all of you who deal with this. And to the extent that we can fix this to make your lives better, and again, to Dr. Wright and others' point, to make patient care better, because I can almost promise you, you're going to be on that table one day. We need to do it. We absolutely need to do it. So, you know, what do you do in the case when it's an emergency case?
I feel like allyship is very important. And so for all the times that, and again, I'm speaking from a residency standpoint, but I think it pertains to lots of things. Allyship from male colleagues is going to be very important in those situations, I feel like, because if it is true that when let's say in a trauma situation, and I ask for a certain thing and it's handed to me, first of all, it goes back to what Dr. Wright was saying about patient safety. If that interaction resulted in something that could have ended with an untoward outcome for the patient, that's a no-brainer. That is something that needs to be addressed right away. But I also think it's really important for allyship. So the people who are standing around, the more senior women in that room, the men in that room, should speak up on behalf of that female surgeon and say, Dr. So-and-so, first of all, let's address all of our colleagues by doctors so that we all understand what our roles are in that room. It's not a hierarchy per se, but in an emergency situation, we need to be clear about our roles. And I would say something like, Dr. So-and-so is asking for this, let's get that. You know, we need to be allies, I think, in that situation, and make sure that the patient's care is not suffering. And then the other thing that I think is I don't know how effective, but I think important nevertheless, is to intentionality about calling this behavior out at every single provider group. So for example, I think we should go to the nursing education, weekly nursing education sessions, and actually let's just talk about these scenarios that have come up and say, what do y'all think about this? Is this acceptable? And I bet a bunch of them, and out of that context, would say, my gosh, this happens to me too. When my male colleagues are asking for something, they get listened to. And when I say, so when I ask, I mean, I figure they have shared lived experiences. I feel like we can call them out through education.
And want you to all chime in, but just something came to mind, Dr. Pei, when you were talking about that. I want to just point out that social psychology principle, those studies from Ash in the 60s, and you've seen them probably on those old videos of the TV shows about, who does what when, and they all were in the elevator and one person turns one way and then they all turn the wrong way in the elevator, and you're like, why would people do this? We have a tendency to want to conform. We have a tendency to want to be accepted and conform. And so just piggybacking on Dr. Pei, what you're saying, and this question about suddenly the shifting and the eye rolling, like if you're a staff member, I think you need to stand up. I guess the word would be an upstander in that point, and say, we need to listen to Dr. So-and-so. This is an emergency. And you can, of course, go back to the patient care. We don't have time for this. Listen to her, let's all go. And that would be an ally on the staff, the scrub nurse, circulator, whoever, it can get your back, because that's how we behave in, again, I picked Apple, but that's how we behave here at Apple, or whatever, that's the behavior. That's not okay to start rolling your eyes at Dr. So-and-so, who's super fun when it's an elective case. And we're not, we need to focus on, again, bringing it back to the patient. So let me just go around the horn here. Dr. Miller, I know you wanted to comment. Let me go to you, and then we'll just have some final comments and maybe a take-home point or two from our panelists about something that you would suggest doing in the immediate term, and even a longer term solution. And again, if there are further questions, I will be back with everybody by email tomorrow, and we'll have other resources here. So don't feel like this is the end. It's just actually the beginning. But let me go to Dr. Miller.
I just want to say a couple things. One is, we know that there's a double standard, and that has to be a zero tolerance. So it's unacceptable for women surgeons to have to bend themselves into pretzels in order to get what they need. The energy expenditure of having to do many more things than the man surgeon would have to do in order to get one task accomplished is just unacceptable. And the second thing that I would say is we need better leadership. So, for the woman surgeon who is not doing anything wrong and just trying to do her job and is respectful and professional and ethical and everything else that we expect out of our surgical professionals, they need to have the benefit of the doubt. So what happens is, somebody gets written up and then it's their fault. And there's no discovery, there's no conversation, and their superior is not on their side. And so the only way to sort of nip this in the bud is that when these things happen, and they will, because of all the gender stuff that we've talked about, the boss has to go back to the nursing director and say, my surgeon, Dr. Miller, Dr. Van Dis, Dr. Temkin did her job fine. Back off, period. There may be room for somebody to be misbehaving, but more often than not, it's the staff that's misbehaving. It's not the surgeon that's misbehaving. Without that support from power, this is just going to continue.
Yeah, absolutely. And again, I think in so many instances, and there are data on this, it does start at the top in terms of creating that culture. And we all need to also be in all kinds of settings, like Dr. Pei was saying, to stand up no matter what your role is. But you do need to have that zero tolerance from the people who have the power to move people, fire people, reprimand people, dock people's pay, things along those lines. Some final thoughts from you guys?
Complaints also shouldn't be like a one size fits all, right? Like not wanting to clean up a food tray is not anywhere near the same as throwing an instrument in the operating room. Yet in every hospital structure that I'm familiar with, they're treated the same administratively. And so we need those people in leadership to have some sort of nuanced understanding of what's a real problem and what's not a real problem. We've created all these safety cultures that are then weaponized as, as tools because you don't like that person, or that person doesn't fit what you think they should be looking like for the role that they're in, and that's just wrong.
Yes,
Yeah, I would
Dr.
just,
Van.
my closing thought, because I actually have to go to call tonight, is, I absolutely endorse what Dr. Miller said, and you've said too, Julie, which is that it can't happen without effective leadership. I think actually medicine needs to imagine that inequity, whether it's systemic racism or systemic sexism or systemic ableism or systemic anti-LGBTQ, it's an organ system that medicine has ignored. So imagine if medicine ignored the adrenal gland or ignored the hematological system. All of this inequity leads to adverse patient outcomes. It leads to people leaving medicine. It leads to burnout. It leads to suicide. There is an entire organism that medicine forgot to teach. And now we have to go back and we have to relearn how those biases are affecting our lives and our patients' lives. But leadership has to care about that. They have to put resources behind it, and they have to have policies that are zero tolerance, as Dr. Pei said. But to me, it is systemic, and it can't be fixed without recognizing the consequences to the people that experience it and to the patients that suffer as well.
And I just want to say there are a couple of questions here that we're not going to be able to get to, but I want to encourage you to either send questions to me that I can, send around and we can think about next steps. And we will give you some action items in the email, the follow-up email that'll go out tomorrow. I know that some of you are wondering, what can I do in the moment and what can we do long-term? And we will help you with that. So I don't want you to leave this discussion feeling like that you don't have direction, you don't have support. We're just going to finish up our discussion now because we've run over, but we will get those resources to you tomorrow by email. So any other final thoughts? Anybody else? Dr. Wright?
I'll just say we were having a little chat here among the panelists about finding your allies. Find the nurses who trust you, find the charge nurses who trust you, find the OR schedulers who trust you, and especially those who have been in the institution for a long time, and lean on them to be your allies to start, because as Dr. Miller said, it is totally exhausting. I think that exhaustion actually makes it really hard for women to advance in their career because they can't change jobs as frequently because they have to rebuild, what they've started when they go to a new location. So, but when you are somewhere, find those allies. And if you are a leader, take those complaints and stratify them and throw out the ridiculous ones, or deal with them from a leadership level and say, these are not the things that we are going to entertain about our surgeons who are doing their jobs. And we're all continuously learning, and I've learned a lot from this panel myself tonight. So again, thanks for including me, and thanks to everybody else for your opinions.
I just want to make sure, let me check in quickly. Is there anybody who wants to have a final closing comment before I close?
Well, if
No?
you don't
Okay.
mind,
I
actually
absolutely
really like this excerpt because I think it harkens back to what we're all saying about the connectivity of how we treat each other in the workplace and patient care. So this is one of my favorite articles. It was in the Harvard Business Review, and it was in the section of gender, and the title is How Discrimination Against Female Doctors Hurts Patients by Christopher Myers and Kathleen Sutcliffe. And it was published in August of 2018. And so this is just a quick excerpt from it. So allowing things to continue as they have for women in medicine is accepting a system where potentially higher quality care is denied to patients due to sexism and bad practices. In fact, the difference in patient mortality observed in studies of male and female physicians is approximately the same magnitude as the improvement in mortality that can be attributed to the last decade of scientific improvement in patient care. This means that excluding female physicians in the healthcare system sets our society back, not only in gender equality, but also in terms of the progress we should be making in medical care.
Thank you. What a great note to close on. Oh, Dr. Vandis.
No, I was just snapping for Pringle.
Oh, great. We've been in this pandemic for a year and I didn't recognize that. All right, well, it happened. I want to thank this amazing panel for joining tonight and for the participants for coming. And like I said, we will figure out ways to continue this conversation and have some concrete things that you can do in addition, or summarizing some of the things that came up today. Let me personally thank Dr. Wright, Dr. Temkin, Dr. Pei, Dr. Vandis, Dr. Tatem, and Dr. Miller for joining me tonight. It was a great conversation. I feel inspired and energized to do more. So we'll see you out there. Thank you,
Julie,
so much.
thank you for putting this together.
Yeah, thank you, Julie.
Yeah, thank you, Julie.
Thank you, Julie.
Thanks, Dr. Tatum, for posting the tweet. Yeah, of course, no problem. We'll see you all soon. Thanks so much.
Take care.
care.